I didn't even know that such a thing as community development existed. When I left school, nobody said there was a career in community development, and it was really only when I was born in England but brought up in Zimbabwe, in Kenya, for WaterAid, and WaterAid had we were seconded. Me and my husband Anthony WaterKeyn was seconded to WaterAid in Kenya, and it was a small organisation called Kenya Water for Health Organisation, Kwaho. And this was my first induction into community development. But I was really a housewife and my talent was drawing. So I used to do illustrations for the training materials, and I assisted setting up a material development of training materials for Kwaho. And while I was in the rural areas, I spent a lot of time in the huts watching the different ways that women look after their children, noting how their kitchens were, seeing the issues of collecting water, seeing the issues of community empowerment, how they were able to or not able to control their own lives. So there was a lot of observation in those early days. And the more I started to draw, the more I realized that I wasn't so much interested in illustrating, but I was interested in the social mechanisms that enable communities to develop. And being a woman and having young children, I really empathized very strongly with some of the problems that women have. And I noticed that, of course, women were very happy to come together once a week because they have quite a grim life. They work all day, they don't ever get dressed up, they have a hard life, looking after children, carrying water, endlessly trying to, support their husbands, but they have very little for themselves, really. They're not developed as women, they're kind of workhorses. And so I realized that instead of going house to house and teaching them one-on-one, really we should get them together, because our strength as women is as a group, and came up with the idea of a health club where we would discuss the ideas that could improve the health of our children. When we came back to Zimbabwe, which is my own country, I wanted to start a program in a country where I didn't have to apply for a work permit, and so incorporate more of the hygiene into it and use health education and hygiene as an entry point. So instead of going in with water supply and inputs, prepare community properly, work with women, try to get their heads straight before we actually got into the implementation. So we turned this on its head and started to work from a different perspective, and that's using hygiene as an entry point. And we registered Zimbabwe Ahead in 1999, having already spent about 5 years doing field trials. The first field trials were 1 or 2 health clubs in Ruambwe Ward in Makoni. We had the Ministry of Health asked us to go there as a particular area they were interested in. And we just found that wherever we started a health club, it really, really took on, and founded the organization in 1999 well. And it was clear that the community health club approach could go to scale. We were able to work at district level, and it didn't matter where it was, the health clubs took on, and we were really confident in this methodology. And it was all set to go to scale. It could have actually taken off in 2000, funding for our project. And despite the fact that it was so successful, we weren't able to replicate and scale up. So Anthony and I thought, well, we don't want this to die. It's too good a thing to let it die, and we'll take it outside Zimbabwe. So we became consultants, and we started an organization which was a regional organization to spread and disseminate what we'd learned in Zimbabwe into different countries. And we called our organization Africa Ahead, based on the same concept, Zimbabwe Ahead. But we really grew out of Zimbabwe, so we've always considered it as the same organization. But Anthony and I are the sort of the scouts, if you like, looking for opportunities to be able to replicate this in other countries. And we went to Sierra Leone. We got clubs started in Sierra Leone. Guinea-Bissau was very successful, working with other NGOs. Uganda did a great program in the northern Uganda in the IDP camps, where we had extraordinary uptake in areas where people were demoralized, they'd been brutalized. It was possibly some of the worst conditions on earth in the northern Ugandan camps. They'd been at war for 20 years, terrorized by gangs trying to abduct their children. So they were all in these camps, there's about 30 camps. We were working in about 15 of the camps, and we started community health clubs. And this is the first time we'd taken it into a high-density situation. And none of the partners had been able to organize the camps to get them to do sanitation, because the IDP people said, look, there's no space for toilets, and we don't really want them. So there was so much defecation around the outside of the IDP camps that the army themselves could not even guard the camps properly, because they couldn't even find a place to sit down. So full of feces it was, you know. We started the concept with Care International. I trained up a core team of 25 facilitators. We deployed them into these camps, and they divided the camps into zones. We had an amazing uptake. We were charged with building 10,000 latrines in 6 months, which, if anybody in sanitation realizes, is almost an impossible target. Nobody has ever achieved 10,000 toilets in 6 months. Well, in 8 months we had achieved 8,760, something like that. After about 12 months it had gone up to 11,000. We surpassed the targets. And this was a great encouragement, because we realized that this is a structure that can be adapted for high-density suburbs, for IDP camps, for emergencies. And that really encouraged us, but we're now going to try and get it into Ministry of Health so that they will run with it. And our most successful example of that is in Rwanda. I think it was about 2010, Anthony was working with UNDP, WSP, and introduced the concept into the Ministry of Health. And they actually liked it immediately and said, look, you've done the piloting, we're convinced, and we'll take it to scale. And the minister himself was very enlightened, and he said, just do it. All 14,000 villages. And then the President Kagame actually said, this is what I want, and I want it now. And so since that time, we have actually gone into, of the 14,000 villages, 90% have got registered community health clubs. And about 34% have actually done the training, which makes them active in terms of, you know, the things that we've been discussing for community health club activities. It was run by USAID and UNICEF in conjunction with the Ministry of Health. And there is such impetus that they are saying by 2018 they will have covered, the training will be covered for every single village in Rwanda. Rwanda is one of the few countries in Africa, I think it's only 3 or 5 countries in Africa, that have met the MDG targets for water and sanitation. And it's largely attributable to the community health club organization in these villages. So we're really hoping that the same kind of institutionalization will take place in Zimbabwe, because this is our flagship project. This is where it all started. This is the place it should succeed first. And the political will is there. There's no doubt about that. It's just the lack of organization of the NGOs and the agencies who are kind of undisciplined by government because there's been a political standoff. And the big agencies like UNICEF have filled the gap where the government should have been, and to a large extent have replaced the control of the sector where it should be with the Ministry of Health. We are very interested in putting the control back into where it should be, the rightful people who are charged with the health of the country, and building the capacity of community health in the Ministry of Health. And we're very encouraged by the Minister of Health, who visited our project last year, saying this is the way to go, this is what we want. So when you look at the trajectory of our organization, we started as a concept. I think we punch far bigger than our size. We are still a very, very small organization, but our ideas are big and our ideas are quite sound. We're unable to continue the programs in Zimbabwe due to lack of funding. I decided the best way to do is to really verify whether our success, that we perceived as success in terms of changing hygiene, was in fact the case. And I took some of our findings to London School of Hygiene and Tropical Medicine and presented them with the the preliminary results that we had from just project records, and they actually said, well, this is amazing. If you can really show that this is cost effective, we're interested. So I enrolled and completed a PhD. My supervisor is one of the gurus of the sector, Professor Sandy Cairncross, and he is now the chairman of our organization, Africa Ahead. We were so encouraged because we found that the programs that we started in the early days in 1999 to 2001 in Chilocho and Makoni and Gutu actually were some of the most effective hygiene promotion projects in the world, internationally. When we did a thorough research and looked at similar sort of projects, it was very difficult to touch the kind of levels that we'd achieved. So we were then given the kind of self-confidence, really, to lobby much more strongly for our approach. And so Anthony and I actually are more in the role of sort of advocacy. We do spend quite a lot of time writing papers, preparing presentations, going around to different conferences and talking about what we do, and trying to encourage donors to go our route. And we have two extremely good teams. We are able now to provide training. We have the training materials, we have the methodology, and we are positioning ourselves to be able to respond internationally to any interest there is to promote community development in the sustainable way which we propose.